Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, Professor of Medicine and Infectious Diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, February 24th, 2026, we're speaking with Dr. Shibani Mukerji, an Associate Professor of Neurology at the Harvard Medical School. She is a practicing neurologist in the Department of Neurology and the Division of Infectious Diseases at Massachusetts General Hospital. She is principal investigator of the SMOOTH trial, an NIH-funded phase 2 clinical trial testing the effects of a neuroactive steroid in persons with HIV who have major depressive disorder, and she is a vice chair of ACTG 5402, an open-label clinical trial of two different antidepressants in people with HIV who have major depressive disorders. A dedicated advocate for the next generation of researchers, Dr. Mukerji has served on the American Academy of Neurology Clinical Research Subcommittee since 2019, which supports awards for medical students and first-time investigators. She also serves as chair of the AAN Neuro-Infectious Diseases Award Committee and chair of the Massachusetts General Brigham Neuroscience Institute Awards Committee. Her lab focuses on HIV pathogenesis in the central nervous system, and her focus clinically is on neurology-infectious diseases with specific interest in neurologic complications and aging in people living with HIV. Today, Dr. Mukerji joins us to discuss the presentation she gave at the Conference on Retroviruses and Opportunistic Infections entitled Cognitive Aging in HIV, Clinical Assessment and Management. Shibani, welcome to the podcast.
Thank you, Michael. Thank you for having me.
It's great to have you here. Let's talk with you. What about you? Tell me about how you ended up at Mass General. What was your journey?
How I ended up at Mass General. How do I end up as a neurologist in an infectious diseases division?
That is unique, for sure.
So, I was preparing for this question, Michael, and I have to say it is not a complicated story. It was actually pretty linear. I was a PhD who was doing neuroscience, and I'd been in neuroscience since I was about in my early 20s. And I expected to be a stroke neurologist because my PhD was centered around neuroscience and survival of neurons. And then I met Dr. Lewis Rice. Do you know Lewis Rice?
I know of him.
Yes. So he was at the Veterans Association in Cleveland and actually was chair of medicine there. And, if you know him, he's a towering figure. And I was a third-year med student coming out of a 4.5-year research lab, didn't know how to talk to patients, very nervous. And I'm probably 5'4" on a good day. And so he was incredibly kind, charismatic, and encouraged me to go and see as many patients, talk to them, whatever they needed. And so the VA in University Hospital in Cleveland basically had a type of ward where a lot of people with HIV were living and veterans. And so my senior medical resident encouraged me to do phlebotomy because he said, you never know, you'll need it. And so I became very good at phlebotomy. And then he said, well, if you can do phlebotomy on people with HIV, get to know their story, you'll be really a successful person.
Yeah.
So it's about 2007, 2008 when this is happening. And I get to hear the stories of veterans with HIV. And it was just a joy. And it was the first time I'd ever thought, oh, goodness, I should do medicine, not neurology. Anyway, I end up going into neurology. I end up then in my intern year at Mass General Hospital in medicine, I decided to do my rotation in infectious disease. Mm-hmm. And there I meet Athri Cybris, I meet Rosia Picado. We're talking energetic, powerful people that just love infectious disease. And I really thought I made a mistake. But I become a neurologist and I couldn't stop. I just kept loving infectious diseases. I gathered patients in my clinic who had HIV. We had patients with TB, and I became sort of the in-house expert. And at the time, 2012 was a big peak in Eastern equine encephalitis. And so I became the person who saw the most number of cases, and I got to meet families. And so it convinced me that I was going to drop stroke neurology, and I was not going to do research in there. I was going to shift my entire research career to a field that I had never studied in my life. It was going to be virology and immunology. And in order to do that, to be successful in a lab and to write grants, I had to do a postdoc. And it was a big commitment on my family's part because I, after residency, commit myself to a postdoc, a basic lab type postdoctoral fellowship. And the person I decided to do my fellowship is a woman named Donna Gabusta. So Donna, if your audience doesn't remember, so Donna person who was also a practicing neurologist, was a resident in our residency system. And she is one of the first people with Marty Hirsch to describe the virus in the brain. So she's got these papers and she's and she's describing this new entity, HTLV type 3, what it's doing to patients, how you can find it in the brain. And I have to say, coming into her lab in around 2000, I would say 14 at that time, she was willing to take on a person who had never done virology, never done immunology, and sort of teach her, that was me, about how HIV affects the brain. And so I was there for multiple years. Donna taught me sort of everything I knew, opened the doors for me. And so I have never looked back.
Yeah. Well, your story is wonderful on many levels. First off, for younger trainees who are differentiating in their path, I think one of the things that I always say is it's a lot of it is serendipity. It's the impact of a mentor or a acquaintance, even attending who you're with for just 2 weeks, that sort of sparks an interest that you didn't know you have, and then you just sort of follow that passion. So here you are, and we're talking about HIV in the brain, but more as a clinical manifestation. The good news is, of course, that people now are living long lives with HIV, and that's something to be celebrated. And all of us, especially me, are getting older. And as we get older, there's common things among people who don't have HIV, and there's common things of people who do have HIV. But I don't think there's enough neurologists who are working in HIV, so it's lovely to have you here and to have you talk to us about that, those differences. We're going to be speaking to Alan Winston on a different podcast. We're going to get into some of those differences, but let's focus in the here and now.
Okay.
Patients who are coming in to see you, who might even be in their 30s, 40s, maybe early 50s, and you're thinking not only about their overall health, you're thinking about their brain health. Let's talk about that. How do you prepare them for when they get 64, like the song says?
So, that's a great question. And I think I'm going to step back, Michael, and just simply say, when you talk about serendipity, I couldn't agree more. And when you talk about mentorship, again, couldn't agree more. So we were actually lucky. So at Mass General Hospital, probably since the 1990s, Nestle Basgaz had brought over and actually recruited a neurologist from Boston City Hospital, which is a very famous hospital in Boston. And she recruited Naga Gopal Venna, and I'll call him Gopal. And essentially, he was a neurologist who had seen and started in the 1980s seeing patients with HIV in a public health hospital. And he knew all the manifestations of neurological manifestations. You name it, he saw it. And so he comes to Mass General in the 1990s to start up the clinic in infectious disease that is solely neurology. He's the neurologist billing under infectious disease, sitting there, and he's with the HIV fellow, and he's teaching them how to care for patients with neurological complications. And so, so I'm in this clinic that's been there, by the time I'm there, 2 decades, well established, and I'm training under him. And then I become an attending inside that clinic. And so I have HIV fellows with me and we do talk. So by the time they come to see a neurologist, they've already discussed that they have problems with their primary care physician. And the way the clinic is set up, you have to have an infectious disease physician that inside the clinic that referred you. Mm-hmm. So they've already talked to their infectious disease physician, and, top two things we see: cognitive disorder and neuropathy.
Yep.
And when it comes to the cognitive questions, a lot of it is brain health. A lot of it is you're trying to figure out, sort of backpedal, what it is that they're really concerned about. What is their memory questions that they really are afraid of? And a lot of them actually don't have cognitive impairment when they're seeing me, but they're afraid that whatever memory question that they had, they couldn't remember their keys or something, is going to pretend it's something really bad. So it is a wonderful opportunity at that point to say, okay, how are you sleeping? What medications are you really taking? What are you doing that you're not telling your doctor because you don't want to disappoint them and you're taking on the side?
So that could be substance use.
It could be absolutely substance use. And so substance use disorder, I think, is actually well discussed in ID and primary care clinics for people with HIV. I think that language is there. But other substances are actually not discussed that actually do have CNS effects. So I'll bring an example. I had one patient who was taking Benadryl to go to sleep. Common. Mm-hmm. And that was just becoming an obvious problem for long. And they weren't telling their physician because they knew their physician would be upset about it. And so we have to dive down into what's actually the sleep problem and why you're taking it in the first place. So that's one. The second was actually a person who was having a lot of trouble at work because they were having actually headaches. And to the point where they had to take off from work and they just couldn't remember certain things and they were not sleeping. And they ended up having too much caffeine, which, by the way, is a stimulant. It's the number one stimulant around the country, around the world. Exactly. It's, but basically it is also a product that's put into a lot of supplements now, a lot of energy drinks, a lot of weight loss drinks. And so he was trying to lose weight. And he was drinking a supplement, drinking Slim Fast, mm-hmm. to be blunt, that had a lot of caffeine in it, and he wasn't aware. And so all of these things are just educational pieces. And it's not specific to HIV particularly. I could be talking to whomever about healthy sleep habits and healthy sort of food habits. But I do think people with HIV are engaged in care a little bit earlier. So it's an amazing population. They're already comfortable talking to providers because they've been doing so for a very long time. And so they're more prone to think about, I'm afraid what my future is going to portend.
And I think if we dig deep, all of us, I'll be general, are worried about the future regarding our brain. We've either had a parent or a grandparent who had advanced dementia, and we saw the horror of that. And so we wonder, is that going to be me one day? Is this a Damocles sword that's waiting to attack? But I think with HIV, it's even more so, because before in the treatment era, a lot of people had what we used to call AIDS dementia complex, which is a different thing. But it's a scary thought for kind of all of us, but especially for people with HIV.
Extraordinarily scary, especially for those individuals, which I had termed longest term survivors. So people who'd lived in the AIDS epidemic never really thought that they'd enter into older age. So they saw their friends dying of dementia complex, mm-hmm. dementia. And they're wondering, and then there's messaging that, if you have HIV, you're going to have a neurocognitive disorder. Like 1 out of 2 people will have this neurocognitive disorder, and you're just waiting for the shoe to fall.
Yep.
And so I think that, and as you put it, I have a family member that has Alzheimer's disease, and that's actually the top thing that I hear more than anything. I have a family member with Alzheimer's disease. I'm wondering if my memories, that this is a sign.
So we aren't going to probably have time to go into peripheral neuropathy. So let's just focus on CNS. So I think there's 2 things that we can really dive into. One is those patients who are referred to you who are already manifesting some degree of symptoms. They may not be Alzheimer's for sure, but there could be some cognitive impairment. So you're going to take a good history. You're going to focus on the things that might be contributing that aren't necessarily, let's call it organic brain. I don't think they use that term anymore, but primary neurologic dysfunction versus something that's going to accelerate that. A issue that is you can do something about, modifiable. Yeah.
Again,
So take us through your approach and what we might do that you'd be teaching your fellows.
That's great. So I think there's a lot of agency that we have to provide to people that they can do certain things. And so a couple of things that we do talk about. So the first thing is you have to get to distill down the symptoms, sort of why we're having this conversation in the first place. And it does take time to figure out a person's why. So usually it's some fear that they have. They're starting to use calendars. They're starting to use their phone for note taking. They realize that they're having some problems. And so usually when you're starting to try to suddenly adapt things that you can't remember anymore, that is something that we want to take a little further and to see what's that reasoning. Missing appointments, sometimes when a person never missed appointments, things like that. The other thing that people don't always recognize is when, familiarity of places. If you're going to the grocery store and, you should know where things are, but you don't. So you're forgetting that and you're not able to learn new things. That means a little bit differently than I would say when someone looks at you and they pretty much say, I went into a room and I forgot what I was going for, so I had to go back. But then I remembered, so I went back in. The fact that you remembered and went back in, it's probably you weren't paying attention.
Mm-hmm.
Maybe there's a lot of things on your mind. Maybe you're exhausted. All of these things is very different than I'm going to a grocery store and I don't know why I'm there in the first place. So that distinction of severity is really important, extraordinarily important. And so you can ask very simple things, what exactly is an activity that you're doing that's harder now today that you were able to do 6 months ago? What are you having trouble with your new phone? And if they say, I went to someone to teach me and now I can't remember, it's, versus I just can't understand this phone. What other things that you're trying to do a workaround for? Are you putting notes everywhere? That makes me believe that you're having some trouble with instrumental activities of daily living. And so you're really going down the route of, and as I phrase it, so you have instrumental activities of daily living and activities of daily living. I liken it to instrumental is the person who just, your 18-year-old that just got their new apartment and they have to figure out how to live on their own. And so they have to pay their bills. They have to, pay, get food. So that's your instrumental. And then you're worried about the activities, the stuff that a toddler does and is no longer able to do. So that instrumental is, you used to be able to do it, but now you can't. So that's the set of phrasing that you really want to get to.
So you determine that there's something happening here. What it is ain't exactly clear, and then you dive in, and you're thinking first, I would guess, about what are the modifiable things.
Absolutely.
And one of the things that we encounter a lot in people with HIV is depression, sometimes occult. So how do you tease that out?
So before we are able to do that, I actually go through their medications.
Okay.
Because that will tell you a little bit more about, and if you have 3 medications that affect the brain, then we really have to go through and try to figure out and eliminate one. So that's actually the 3 or more is actually an American Geriatric Society number. So it's not a sort of out of the blue. That's something that we look at very quickly. The second that we look very quickly also is trying to figure out other substances that may not be on your list. And the third thing that we really try to do is try to figure out what substance uses that you're having that maybe you're not talking about. So those are the first things, because depression is a symptom of cognitive disorder and neurodegenerative disease, but it's just also a symptom of anxiety. It's a symptom of a lot of different things. So you can't get to the depression before you sort of figure out some of these other external factors. But the depression piece is largely straightforward. For us, I have the PHQ-9 now memorized in my head. And you go through those, and it's conversational. It's not like you're looking at a list and check by. It's like really conversational at this point. And so that's when you sort of say, okay, you have a high depression symptom. That doesn't mean you don't have a degenerative disorder. That's a separate question. But we've got to tackle this first. And so that's when you really try to make sure that their depression is taken care of.
And one thing I think all of us need to keep in mind is that depression is a disease of the brain.
That's correct.
It's the mesolimbic dopaminergic pathway with you get your yes, and if they're not firing, then you're depressed. And so there are drugs that we can use for that, and you're doing studies on a couple of those. Some other things that seem to be modifiable are sleep.
Right.
And we're finding that there's a lot of people with occult sleep apnea, meaning they have it, but nobody knows it. How do you assess that?
So there's a couple of actually straightforward ways. So the most straightforward, I think, is like stop paying or something like that, like these validated items. For us, in order to get a sleep study, we have to do the Epworth, like daytime sleepiness scale. So in order for us to get that, we have to do it. But basically, it's not just snoring that people assume is sleep apnea. It's really daytime fatigue, and really trying to understand if you have severe daytime fatigue versus just normal fatigue in some ways that people have, sort of more mild. But if you have daytime fatigue, you are not able, you feel like you're getting a sleep, like a long enough sleep, and you're still fatigued in the morning. I think it's an opportune time to think about a sleep study, and it can be a home sleep study. There's pros and cons for that. But I do have to say, getting a home sleep study, even if that's the only thing you can do, is very helpful, even as a biomarker, to just see what else is going on.
I mean, we've gotten a lot of sleep studies, and by the time we refer, it's like 98% of them come out with a prescription for a CPAP.
That's correct.
Right?
Yeah.
And so it's woefully underdiagnosed, and that's something else. So we assess them, we dig into the medications, we assess sleep, we assess depression. One of the things you talked about in your talk were the pillars, the five: movement, sensing, touch, balance, cognition, and emotional health. Yeah. How do you go about this, like in a methodical way, and say, I'm going to go through all these pillars, or can you do all that in the first visit?
No, and I think this is where I think the conversation is a much more longitudinal one, because I think everyone wants to do this cross-sectional big time assessment of everything, and then it's dropped for the next 5 years and it comes up again. So I think that's almost impossible. You can't do it. It's overwhelming to a patient, actually.
Right.
And so, there's nothing wrong with a stepwise approach, especially, neurodegenerative disorders that are accelerating or at the end stage. So, if you can give yourself some time, you can take care of things over time. So the answer, I just wanted to go back a little bit. The sleep study, we talk about sleep apnea, but there's another piece inside of there that we talk about is actually restless leg. And so those periodic movements of sleep studies can also figure that out as well, which can disrupt your sleep, and there are treatments for it. And so there's opportunity there. So to go back and say, okay, you figured out your sleep, you figured out the medications, and the person is now in therapy and on an antidepressant. What are some of these pillars that you might be thinking about? So the movement, I'll take movement, senses, and balance. Those usually go together for me, just conceptually. How much are you actually moving? Not exercising, moving. Because, if you're sedentary, your pain is going to just increase over time. So how much are you able to move, and what are your barriers? And then hard objective metrics. We in our clinic actually have a piece of carpet. So it's carpeted, but this carpet is a different color. And it's, 25-meter carpet. And we use that to time. So we use it from MS. Almost every disease that we have, Parkinson's disease, we use that metric. Geriatricians use that metric, frailty, everything. So we have this and we time it. And there are benchmarks of what you should expect. Now, if you have disability and a variety of different things, it's a separate question. But for people, you should be able to walk that 25 meters. And that is actually the benchmark that you use. Like, how much are you able to do? Balance is another one. If they can't walk it, they're going all over the place. Yeah, you need to figure out what is it that's driving that.
Mm-hmm.
Because fall is your biggest issue.
One of the things that I've noticed, it's not an epidemic kind of thing, but I've seen a lot of our patients as they got older who do end up having Parkinson's.
Yeah.
And I'm hearing that perhaps the pathogenesis of that is neural inflammation.
Mm-hmm.
And so patients with HIV, before they were ever on antiretroviral therapy, had HIV in the brain, as you were talking
That's
about
right.
with Dana. And then there's inflammation that happened there, maybe that set off a pathway for the development later in life of Parkinson's. So are you seeing an increased incidence of that or prevalence?
So it's very hard to say the increase because you can see Parkinson's in older individuals. And so to see that increased number is actually a challenging thing. And so sort of that epidemiology is going to be hard. And so I will say this, the one thing that is a challenge for us in people with HIV, and this is anecdotal, and I'll say that, but it's hard, it feels harder to treat a person who has HIV for, and it was of that era and then has Parkinson's. So it's just a little bit more challenging for us to treat.
Yeah.
And so I don't know if that is because of, whatever happened in the past. And now on top of it, they have Parkinson's.
So that would be an example of the movement disorder and the balance. You also mentioned something simple like hearing loss, which is common. I mean, I've had a hearing aid for 4 years now, and I can relate to that. It's a little scary because it's not getting better. And as it gets worse, I notice that if I'm not focused, conversations can go right by me. And tell me that connection with an increased risk of cognitive impairment.
So it's a good question. And I think research really needs to be inside this field. So it's understudied. So what was interesting about the Lancet Commission is that they said hearing loss during midlife is what was the predictor of risk for dementia. Vision loss in late life is a predictor of dementia. We focus a lot on vision. We have these annual eye exams, we focus a ton. We don't focus on hearing. I've yet to see people saying they need their annual hearing test because I never thought about it either. And so I think we have hearing loss. People don't realize it. They're losing those high-pitched noises. And it's only until you get to a specific amount that you start to realize that you can't hear things. And that's sensorineural hearing loss, right? And so there is a period of time that you might be a good missing conversation. You weren't engaged, you're missing some things. It's unclear on a mechanistic level why that is. We can hypothesize, but it's unclear. But it's clearly important for your eventual cognitive health.
Yeah. So that goes into the mixed bag. And then you also mentioned emotional health and the ability to kind of engage with people and that type of thing.
I love it. The great thing when the Surgeon General said we have a crisis in older men because they are socially disengaged. And then they said that that's a crisis, right? Absolutely. There's something about being social that is so uniquely human, right? There's a lot of theories about this. We evolved because we were social animals, and that's how we survived theoretically. And we create these cities and these like huge populations, and then we are social beings. If you want to really harm a person, getting kicked out of your social network is one of the most harmful things to think about. Animals, mice that are kicked out of the social are actually at huge vulnerabilities of disease and mortality. So I don't think we realize that. I think we take it for granted that we're social people. There are introverts and there are extroverts, but fundamentally social. So there's something about our brain that needs it. And the moment you have people isolated in their house all the time, who knows what the brain is doing? It's thinking, it's its job. It's thinking all the time, right? Yep. And so, you have sort of these conversations in your head, maybe anxiety in your head, and you can generate a world that's not engaged.
So that's also obviously part of your assessment. Do you use your team to collect some of this information for you? Like, are they living alone? Do they have networks? You probably don't have time yourself to go into all that. So how did you organize your team to collect that information?
So we actually rely very heavily on infectious diseases social workers. So social workers for us are actually probably an anchor for what we use, because a lot of the social workers are by design trying to figure out what a person has as a support system. And then we actually have community health workers. So for us, our community health workers are really good at knowing what in the community is available and what help they need. So for us, the reliance on those types of individuals is exceptionally important. And then case managers, if available, can be really helpful at what we need to bring in to support a person if they decide to live in.
So, as I would have guessed, our time is flying by. And so we're going to need to kind of come into a wrap up. So you've talked about models of care, symptom assessment, HIV health status, are they suppressed or not, medications, substance use, maybe even occult substance use, sleep, mental health, the exam and how people are moving and that type of thing. One thing you did mention maybe we can wrap up on is what I wrote down as the Valcour tripod.
Yes.
So Victor Valcour, for those who aren't familiar, is a wonderful, I think he's family medicine trained initially, and he got into, when taking care of older people, evaluating their dementia, and really has become, in essence, a neurologist.
That's right.
So remind us all about the Valcour tripod. It went to a talk he gave at CROI
2019, yes. So a very beautiful talk. So I do recommend people look at it. But basically, the tripod is cognitive, motor, mood. And so cognitive was concentration, attention, and brain, what we call brain fog or mental fatigue, really. And then you have movements of tremor being uncoordinated, and movement, and mood, which could be apathy, more rarely mania and agitation. So, that's the tripod. Mm-hmm. The key core fundamental about that tripod is you have these set of systems. You don't need all of them. But the big thing is the time course, because most people with a cognitive disorder that we think is related in part to HIV specifically is that it fluctuates. And that I didn't bring up, but I want to sort of highlight, there's a fluctuating course. It's very different than age-associated neurodegenerative disorders, very different. Alzheimer's disease is fundamentally different. It's a problem with actual memory, specific types of memory. And it's out of proportion to age. So you decline in that. There can be small fluctuations, but honestly, you're declining. And so why you're talking about what happened in the last 6 months and 1 year, you're trying to figure out that course, the declining course.
Yeah. Well, I think it was in his talk that he used the analogy of a jukebox. You heard that? But so the jukebox analogy is that with just almost normal aging, when we go to pick a record, we go to jukebox, hit B4, and the little thing goes and it looks for the record. It might have to look a little longer, but it finds the record, and once it finds it, everything's there.
Yes.
So that's kind of processing.
That's right.
But with Alzheimer, that looks for the record, and the record is gone.
That's correct.
And so it's hard to repair that. And it's hard for us even to relate to that. But that processing thing, I think all of us, I know your name, I can't remember. Yes, and then finally you remember, go, oh, yes, and we were, yeah. So that's kind of something I learned from Victor years ago.
That's amazing. So I have to say the National Institute of Aging actually has a whole series of infographics and videos that say what is normal aging, and then what is Alzheimer's. And that is probably the best source of trying to figure out, is this something I should be scared about? Is this not?
Yeah. So we are sadly out of time. Just where do you hope we are 3 to 5 years from now? What would you like to see the field in neuroscience, with especially the intersection with HIV? What would you like for us to be doing?
I would like for us to have guidances, actually U.S. guidances on what brain health means for a person with HIV, and really be clear of what we should be looking for. So that's one. The second is I would love to see clinics, Brian White and community clinics, really can we come up with a model that works for them, that they can embrace, not a burden, and it's actually a benefit. And so, to be specific, someone came in afterwards and they started an aging program. They are Ryan White. And they said, not only do their patients love it, the providers and everybody in the team loves it because it feels like they're doing something.
Mm-hmm.
And so that becomes normalized. This is like an obvious, why didn't we do this before? That's what I'd like to see in 3 to 5 years, that we've come up with a system that works for different models, different clinics of care.
Well, Shibani, it has been great talking to you. I wish we could clone you and have a Shibani in every Ryan White clinic. We have a neurologist who works with us. It's wonderful, but she's so swamped with really deep problems, stroke folks and seizure folks, and I mean, like the usual neurology practice, on top of assessing for Parkinson's, dementia, whatever. But it's great being with you. Congratulations on a great talk yesterday. Everybody can sort of find this talk. Once the meeting's over, all these talks will be released and available on the web to everybody. I highly recommend it. It was a great session with other great speakers too. But thank you for being with us and joining the podcast.
Thank you, Michael.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.